All right. Hello, everybody. We are starting the Innovations in Kidney Transplant Conference session today with Dr. Jens Gobel. He is out of the Helen deVos Children's Hospital in Grand Rapids, Michigan. So today he'll be going over innovations in kidney transplant. I am personally pretty excited about this. I have a kidney transplant daughter. She's 15 and she is really into engineering and has been looking into all sorts of research on this. So I would love to hear Dr. Gobel's perspective on everything that's out there and hopefully will be coming out soon. All right, we are ready.
Well, thanks, Jen. I'm going to try to share my screen, and we probably won't cover everything because we only have 20 or 25 minutes, but I'll do my best. Let's see. Here we go. Can you see my screen now, my slides?
Yes, it's perfect.
All right, so Jen already mentioned where I'm coming from. So officially I'm a Spartan. Well, that's just the tip. That's just the tip of the iceberg. I'm trying to advance my animation here, and that's not working. So let me see if I go over here. I'm having trouble.
It looks, I can see your screen, so you just can't advance.
Well, so I'm doing the usual things that, let me see here next. There you go. Okay.
Perfect.
So I have no conflicts of interest. We're supposed to talk about innovation, so we need to spend a little bit of time looking at whether we're really making progress, because otherwise there wouldn't be any innovations to talk about. So I thought we'd spend a few minutes talking about this complicated slide, but I think it's worth it. So this is the death-censored graft failure rate, so a bad number that should be as low as possible in pediatric kidney transplant recipients of a deceased donor kidney by transplant era. So kids who got transplanted in 1999 or 2000 versus kids who got transplanted in 2005, 2006 versus kids who got transplanted more recently. And those graft failure rates are broken down by how soon post-transplant these grafts failed. So for a child who got transplanted in 2001 or 2002, there was about a third. If you look at this line here, this greenish, bluish line, there was about a 30% chance that after 5 years, that graft might have failed. And this is the 10-year graft failure rate. And then these are more short-term graft failure rates. So what you can see is that over time by era, all these rates decreased, right? And failure rates are a bad thing. So decreasing failure rates are a good thing. And things decreasing over time by transplant era means we are making some progress. And that's really what this slide is supposed to show for pediatric deceased donor kidney recipients. Just to compare it with living donor recipients, which is going to happen on the next slide, I'd like to point your attention to the 10-year graft failure rate for kids who got transplanted with a deceased donor kidney in 07, 08. So that number is what, 38%? So if you go to a living donor graph and look at the same era and the 10-year graft failure rate, that is at about 28%. So that's indication that, of course, living donor kidneys are somewhat better than deceased donor kidneys, but deceased donor kidneys are still a heck of a lot better than having to stay on dialysis. And again, all these lines are trending down, so we are making progress. So what are these innovations, or some of these innovations that we're talking about? Well, it's summarized in that paragraph about my talk. Improved blood pressure control, cardiovascular health, which is a big deal in kidney transplant recipients, pediatric and adult, reduction in acute rejection, and improved quality of life. So that's what we're talking about today. We're going to start with cardiovascular disease, which in the setting of kidney transplantation and the setting of the unfortunate obesity epidemic in this country and on this planet, I call the obesity epidemic on steroids. But problems have been there regarding cardiovascular disease for a long time. So this is a very old slide, but a very telling slide, I think, that tells you the annual risk of death in patients who either are renal transplant recipients, those black squares, or the general population by age group. And it doesn't even have kids in it, but it shows you trends that you can extrapolate. The other thing to keep in mind is that this y-axis here, this vertical axis, is not like 1, 2, 3, 4. It's 0.01, 0.1. So this is what we call a logarithmic scale. So as you reach each one of these lines, your number actually increases by a factor of 10. So if you look at renal transplant recipients who get transplanted when they're 65 years old, their annual risk of death from cardiovascular disease is not a whole lot different from the general population. But if you look at younger kidney transplant recipients, their curve is a lot flatter than the general population. If you extrapolate these lines into the pediatric age group, you can tell how much higher the annual death risk in pediatric and young adult kidney transplant recipients appears to be compared to the general population, where in that age group, of course, the risk of cardiovascular mortality is not very high compared to older age groups. And so that bears out in more specific data. If you look at what does cause of death, what does cardiovascular disease do to transplant recipients in the adult world, it is the most common cause of death in adult kidney transplant recipients. Unfortunately, it's also a cause of death in some pediatric kidney transplant recipients. NAPROTEX is a big pediatric kidney transplant and kidney disease database here in the US. And pediatric kidney transplant recipients indeed have a 10 to 100 times increased risk of cardiac death compared to the general pediatric population. So you're going to say, well, why are you doing kidney transplant for kids? Well, because that cardiovascular death risk in children on dialysis is actually 1,000 times roughly higher than the general pediatric population. So you do these kids a cardiovascular death risk favor by transplanting them, but you still have a tall order as far as how to further minimize this risk and what to do about it is concerned. So what are we doing about it? Well, of course, we're trying to address cardiovascular disease risk, not just post-transplant, but also pre-transplant. One of our latest and greatest modalities to do that is what we call, hey, where did my animation go? Is ambulatory blood pressure recording or 24-hour blood pressure recording. This is what these devices look like. And I hope if you have a child with a kidney transplant who's at least 6 years old, because you can't really do this in younger kids, that your child has had one of these. They give you a very accurate picture of somebody's blood pressure during the day and at night. And nighttime hypertension otherwise will go unrecognized and can be a big problem. This is a normal ABPM. Daytime, you can see here, it started at 9:20 in the morning, and then at 10 something, this person went to bed. So your upper lines, your upper normal ranges for the first blood pressure number, the systolic number, and the second one, the diastolic number, decrease at night because we're all supposed to lower our blood pressure at night. And this person has perfectly normal first and second systolic and diastolic number, both during the day and then at night, because they have good, what we call nocturnal dipping. This is a 24-hour blood pressure recording. This is from a 12-year-old kidney transplant recipient who decided to start the study at night, 10 o'clock at night. But I'd like you to look at the daytime readings that start around, what, 7:30, 8 o'clock here. And if we saw this person at 10 o'clock in the morning in clinics with these blood pressures, we would have said, oh, your blood pressure looks great, girl. Because all morning long during the day, both the first and mostly the second number look normal. But then towards the afternoon and evening, those readings crept up, and this patient has been hypertensive all night long, no dipping. This would go completely unnoticed if we wouldn't do these ABPMs, these 24-hour blood pressure recordings. So that's become a pretty expected or almost gold standard part of our practice in the care of these pediatric kidney transplant recipients and even our chronic kidney disease population pre-transplant. We do other things as well, echocardiograms, other tests to look for end organ damage and things like that. And we have tools, right, to fix all of this. We can make people exercise and lose weight. We have a bunch of blood pressure medicines to normalize people's blood pressure. If there are problems with cholesterol and triglycerides, we have drugs and stuff for that as well. We can fiddle with some of the medications we use for the transplant recipients that are notorious for increasing cardiovascular disease risk. So we should dominate this, right? Well, the truth is we aren't, which is why there's a question mark flying in from the side. This is an example from a study done in a number of Midwestern pediatric kidney transplant centers that looked at cardiovascular evidence of disease, of illness pre-transplant and then 1 year post-transplant. So it looked at body mass index, how obese are these patients, at blood pressure, at high density lipoproteins, so a type of basically cholesterol, at triglycerides, and at glucose. And look at that, none of it got better within a year post-transplant. Some of it actually got worse. So we're not doing a good job managing cardiovascular disease in our pediatric transplant recipients. This is another way of looking at it, and all you need to take from this is that these bars are all over the place, because they are. These are 8 or something different pediatric kidney transplant centers, again from the Midwest, looking at what do they explore at each visit with their transplant recipients. And once again, the bottom line is it's completely chaotic. Every center for every one of these different cardiovascular disease risk factors practices differently and fairly unreliably. So even though we should have the tools to assess and manage cardiovascular disease risk in our pediatric transplant recipients, historically, we haven't done a very good job. So we tried to leverage some new things to change that. And those new things are mostly quality improvement, which is sometimes very hard to do. And we founded this improvement network called Improving Renal Outcomes Collaborative, because every single center by itself probably won't be able to do a good job. We need to work together and learn from each other and try to move the needle as a group. And so we currently have over 40 American pediatric kidney transplants who are members of IROC, which captures over 60% of all children who get a kidney transplant in this country. And we sort of move our goals every so often. We started out with better blood pressure management in transplant recipients and did an improvement project network-wide. And all you need to see here in the middle is that something got better, which is the accuracy of blood pressure measurement in pediatric kidney transplant recipients enrolled in IROC, or where the centers are enrolled in IROC after performing some interventions. And of course, we're optimistic that that'll eventually help us come up with better interventions to reduce complications of hypertension in pediatric kidney transplant recipients, now that we're at least able to more accurately measure blood pressure in these patients. IROC has also helped very preliminarily get us started on reducing rejection. As you know, one of the more recent tools, as you probably know, to look at immunological risk and risk of immune injury, i.e. rejection in transplant recipients, is to monitor their circulating levels of donor-specific antibodies. Oops, that was a little premature. And this just looks at over 20 IROC centers and how often they do that. You can see initially pretty often post-transplant, and then many centers do it every 6 months in the first in the first 2 years post-transplant. That's why these bars are the highest. And so figuring out, and there are actually now guidelines for how and how often to do this DSA monitoring, figuring out how we can use DSA monitoring to help reduce the incidence of rejection is another opportunity to leverage the power of having a network like our IROC. And so we're working on that. We're also trying to reduce rejection by improving adherence. And this is a single center study that just came out from one of the bigger centers within IROC from Cincinnati. These people developed this medication adherence promotion system, MAPS, which basically means when you bring your child to clinics, you get a quick questionnaire, and so does your child, depending on age, about barriers regarding medications taking. Too many pills, they don't taste good. I forget to take them. I don't like the flavor of them. And then they have an established pathway where, depending on what your concerns are, your child's concerns, you get some help from the pharmacist, from the social worker, from the provider to make an improvement. And then as part of this study, Cincinnati was able to pilot this MAPS tool. And then they looked at, has this changed anything in how often we biopsy our transplant recipients and find rejection? And they found that the incidence of acute rejection after they implemented MAPS went down by 50%. And then last but not least, this is another single center study about probably quality of life overlapping with rejection prevention. This looked at what happens if you convert patients, pediatric patients, from the regular twice daily tacrolimus dosing regimen to the now available and FDA approved for even fairly young children, once a day long-acting tacrolimus regimen. And it looks at the variability of tacrolimus levels on twice daily regular tacro versus after conversion. And variability of tacro levels has been associated both with the development of DSAs, which are usually bad news, talking about immunological risk and rejection risk, and with adherence or non-adherence. So the lower the tacro level variability is, the better. And you can see that switching from twice daily regular tacro to once daily long-acting tacro seem to be beneficial long-term. And in this study, single center from Children's Colorado, which is why when I worked there, I was one of the co-authors. In this study, we felt like we showed in a promising way that this might be a good thing. And we also documented that graft function was unaffected by this conversion for at least 2 years after we did that conversion. So in summary, innovation is happening in pediatric kidney transplantation. Quality improvement approaches via learning networks allow for the development and implementation of such improvements on a larger scale. And current and future focus areas of such innovations are cardiovascular health, rejection reduction, and improvement in quality of life, as I mentioned. What I didn't mention because of time constraints, those focus areas probably also include further advancing non-invasive monitoring, for example, screening for donor-derived cell-free DNA now, and of course a big one, which I think is also being addressed specifically in this conference, is transition to adult care. And with that, I thank you all and hope that we have 5 or 6 minutes left for questions as I had intended.
We do, Dr. Gobel. Thank you so much. And I apologize. I've totally blinked. I panicked a little at the beginning and forgot to mention that Dr. Gobel here is on the board of directors of IROC, as well as the co-founder. And I also am a part of IROC as a community engagement worker, so as a parent, and the information that has come out of this program has just been so amazing. Dr. Gobel, thank you, especially for the work that you're doing with the blood pressures, the tacro. I did not know that about the long-acting tacro, so I appreciate the studies that you guys are doing on that, as well as the results that you're seeing because of it.
Yeah,
All
so
right.
I'm seeing 3 questions in the Q&A box. Should I
Yes.
answer those?
Yeah, so we'll start with, I'm not sure.
I can just read
I
the
can't
question.
see. Yeah, you can go ahead. Unfortunately, I cannot see the question.
IROC centers are working to lower blood pressure and reduce acute ejections. Is there anything interesting from the nationwide IROC registry you can share with us? So I think I did to some extent. I showed you the accurate blood pressure measurement data that we came up with. We've taken that further where we can now look at blood pressure control in real time and can compare between centers. We can look at, are these centers doing 24-hour blood pressure monitors and what do they show? And we keep track of what they show. What do the echocardiograms show? How reliably are these ABPMs and echocardiograms done? And then we have all kinds of meetings on a regular basis, but the main meetings are twice yearly, what we call learning sessions, where we all get together, now in person again. It used to be virtual during COVID. And we talk about our mutual experiences and we learn from each other and we figure out how we can spread what works and get rid of what doesn't work so well. So I hope that answers that first question. The second question is, when will IROC start looking at quality of life improvement for kidney transplant patients and how? So we did all kinds of basically focus groups and stuff when we got started with IROC, and there was a 3-tier sequence that was identified as top priorities. The number 1 priority was cardiovascular health. So we spent the first 2 or 3 years working on that, and I showed you some examples of that. The second most important priority that was identified was reducing rejection, and we're currently working on that. We're trying to spread that medication adherence assist monitoring systems that map, or promotion system that maps that I just showed you, from the pilot stage in Cincinnati to most, if not all, programs in IROC. And that's currently ongoing. We got slowed down by COVID a little bit, but we're pretty much back up to speed. We got slowed down by some database issues and stuff as well. So we're working on currently on the rejection reduction goal. And then the third top priority that was identified that we're going to focus on next, so maybe starting in a year or so from now, is quality of life improvement. So that's coming up. I can't quite tell you how we're going to do that because we haven't nailed that down yet, but there are lots of ideas and some known strategies how that can be done. And if we don't like those strategies, we'll figure out our own strategies. And then I see another question: how many centers are looking at once daily tacro for kidney transplant recipients? I honestly don't know. If you have a child with a kidney transplant who's on twice a day tacro and you think this is something that would work better for you or your child, you should just bring it up with your transplant program and say, is there a downside to trying? Several centers have been looking at that, both, like I said, to help improve adherence, but also to just improve quality of life, because for some kids, it's a lot easier to take medicines just once a day than twice a day. And of course, one of the challenges that comes with that is that if the other anti-rejection medicine your child is on is CellCept, you're still going to have to give CellCept twice a day unless you can make the decision with your child's transplant team to convert from CellCept to Imuran, which is once a day. And probably once you're far enough out from transplant, may work just as well as CellCept. Not early on post-transplant though. So that's really the extent to which I can speak to that question. And then there's one more question that just came up, and that is how to reduce the nephrotoxicity of immunosuppressants. Well, that's a good question, of course. You know, tacro is nephrotoxic, but usually if you monitor levels and figure things out, you can oftentimes mitigate that pretty well. There are, of course, if there's concern or even evidence, say on biopsy of nephrotoxicity from the calcineurin inhibitor, which is usually tacro, there are other less nephrotoxic anti-rejection medicines like the mTOR inhibitors, sirolimus or everolimus. So sometimes patients benefit from switching, but you know that's those mTOR inhibitors have their own set of potential downsides. So that's again a discussion to have with your transplant team for your child. There used to be 10, 15 or so years ago a period of time where we thought, oh, let's just switch everybody to mTOR inhibitors because they're less nephrotoxic than calcineurin inhibitors like tacro. But then it became apparent that the risk of developing donor-specific antibody on mTOR-based immunosuppression is about twice as high as on calcineurin inhibitor-based immunosuppression. And so now we're a little more reluctant to lightheartedly move away from tacro-type medicines unless there's compelling evidence in a patient that we should really bite that bullet.
Great answers, Dr. Gobel. I did have one follow-up question for that once daily tacro. Have you guys found any of the numbers to be lower, like the tacro numbers generally to go down or to change at all?
No, the levels stay about the same. Of course, the pharmacokinetics of the once daily tacro are different. And so, you know, if you're on twice daily regular tacro, you take your medicine, it takes your body 30 minutes or 45 minutes to fully absorb that dose. So you have the spike in your tacro level to a peak value, and then the level dwindles until you're 12 hours later before your next dose, which is when you get that trough level, that tacro level drawn, because we go by that lowest level right before the next dose to tell us, are we in the right ballpark with our tacro exposure? And then that whole 12-hour cycle, you take it, 45 minutes later you peak, then you go down over 11 and a half or 11 hours to your next trough level and get your next dose. Starts over and over again. The long-acting tacro is absorbed more gently, so you have a lower and more delayed peak after taking the dose, and then the breakdown also happens much more slowly, so you don't reach hopefully your trough level until 24 hours later before you take that next once daily dose. And but that target trough level is just about the same. The preliminary evidence is that the fact that the absorption is slower and more gently, it doesn't reach quite as high of a peak, and a little bit later of a peak as well, and then also the breakdown is slower, actually does help with some of the toxicities of tacro. There's evidence that the trembling that some people experience with tacro has to do with high peak levels. And so if you switch those people to long-acting tacro, where they reach lower peaks, there's some evidence that their tremors will get better.
Wow, that's really interesting. Well, thank you so much for all of the information. If you're in on this meeting, definitely check out IROC online. Our next meeting that's coming up is Kidney Health for All Transplant Patients. So I definitely encourage you to check that out. I apologize, there's a tech issue, so I'm here, I promise. You guys have a wonderful rest of your day.
Thanks so much, and thanks again for having me.
Thank you. Sorry, guys.